Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Michael Barnett. He is an assistant professor at the Department of Health Policy and Management at the Harvard Chan School of Public Health. He's also a primary care physician at Brigham and Women's Hospital in Boston. We are here to speak about some recent research that Michael has published. And welcome to Harlow on Healthcare. Michael, thank you for joining us today.
Thank you. It's a pleasure to be here.
Great. So let's dive right into it. You had recently written about a sort of a natural experiment. Well, a natural experiment, or I'd say an experiment created by the Centers for Medicare and Medicaid Innovations that you were able to observe and analyze. This relates to one of the bundled payment initiatives. I'm wondering if you could describe that in brief, what the natural experiment was, and comment on whether this is something that the centers or others have ever attempted before.
Yeah. So, I think this is, a very interesting federal policy approach that I think has been sort of under-recognized by the, broader community outside of, health policy wonks like ourselves. And so what CMS did is they wanted to implement new payment policies in a way that actually could lead to more robust evaluation. And the first kind of salvo in this new approach, and this was in the Obama administration days when this was put together, was to actually make a new payment model that was actually mandatory, but they'd actually randomize where it was applied across the country. And so for this particular program, which was called Comprehensive Care for Joint Replacement, it's a bundled payment model for joint replacement in hospitals. I can talk more about, exactly what that means and what a bundled payment is for any of your listeners that aren't aware. But the really fascinating thing is that they basically took around, over 100 different metropolitan areas in the country that had enough joint replacements happening to be worth including in this program. And they randomized about, 40% of them to be exposed to this policy. And the hospitals there had no choice, starting from April of 2016, every single joint replacement they did was under this bundled payment model, whereas the other metropolitan areas that weren't randomized to this policy basically just continued with business as usual.
Business as usual, meaning fee for service, or if their patients were in Medicare Advantage, working through a Medicare Advantage plan.
Right, exactly. So the business as usual really means that hospitals get paid for their DRG payment for joint replacement whenever they have a patient, and then whatever happens after the patient leaves the hospital is basically somebody else's problem. Now, I think some hospitals don't view it quite so callously, but from an incentive standpoint, that's basically how it works. There's very little exposure for the hospital to what happens to the patient afterwards, with a few small exceptions.
And then in the experimental group, what was their exposure?
So in the experimental group, the way it worked is basically hospitals were responsible for the entire cost of care, not just for what happened in the hospitalization, but also for everything that happened 90 days after the patient left the hospital. And so that's the episode of care. And the bundled part of the bundled payment is that hospitals are basically paid for everything that happened in that, they're financially responsible for everything that happens in that admission plus 90 days after discharge. The interesting part here is that, all of the other players outside of the hospital, actually in this bundle, they get paid as usual, right? So if the patient goes to a nursing home, the nursing home, like they usually do, if they see the orthopedic surgeon for follow-up, the orthopedic surgeon bills Medicare. But the key part here is that if on average a hospital's patients spend a lot more than the benchmark in the program, or sort of compared to the region or compared to the hospital's historical performance, then the hospital loses money. So the hospital has a risk for the actions of others in that 90-day period, though it doesn't necessarily mean that the other providers in that bundle are losing money. It's really the hospital that's responsible.
Right. So it becomes the hospital's nickel rather than Medicare's nickel. And
Correct.
The hospital, instead of just paying individual claims, has an interest then presumably in managing the full 90-day episode. So what happened?
So what we found is, this program went into effect in April of 2016, and we looked at the first 2 calendar years of the program, so 2016 and 2017, and we compared spending and quality outcomes for the hospitals in this treatment group versus the control hospitals. And it's pretty big. There were over 600,000 procedures in both groups combined. And what we found was that spending basically went down by, on average, over the 2-year period that this program, which we call CGR, was implemented. And we didn't see any change in quality over that period. And when I talk about quality, what we were able to observe was how many people had serious post-surgical complications like a joint infection or the need for a revision surgery, or what proportion of people were readmitted to the hospital. And we also looked for another little nuance, which is some people worry in the bundled payment program that hospitals will turn away patients that are too sick or too poor, socially disconnected, and they're too high risk. But we actually we didn't really see any consistent evidence that that was happening at a large scale. Just maybe a tiny hint that maybe some hospitals were turning away some patients who were disabled, but nothing significant.
So people were able to manage the care and manage the cost once they're tasked with or given a potential upside or downside as a result of that management. Do you see what happened here as generalizable beyond the scope of this particular experiment?
So I think it's a really important question, whether or not this is generalizable. I think that it's an open question. I think right now, the data on how bundled payments have worked across different types of medical care that aren't joint replacement is pretty mixed. For the moment, I'll say actually that the evidence is pretty disappointing for bundled payments that have involved medical conditions like heart attacks or pneumonia or heart failure. There's some positive evidence from government evaluation. There's negative evidence from independent evaluation done by colleagues of mine departments. Whereas for surgical conditions, the data is, really quite consistently positive in terms of generating a modest saving without any clear decrement in quality. So, I guess the short answer to your question is that we hope it's generalizable, and the early evidence suggests that, it might be a mixed bag. And we have to wait really for more data to come out. And CMS is rolling out, bigger, more extensive programs that'll give us a much better picture of exactly how this is going to work across the broader healthcare system.
And you see those as touching other types of conditions or procedures? And do you see those being randomized in the same way, or are these going to be sort of elective demonstrations where people apply to participate in as they've been in the past?
Yeah, I think CMS's commitments so far have really been to these voluntary models where hospitals sign up to be a part of them. There is talk, I've heard talk from CMS officials and, suggestions through their public statements that CMS is exploring the idea of actually pursuing mandatory models again in the future, but there hasn't been no commitments yet. Particularly, it's not like there's been any requests for comments or any concrete proposals put out there, whereas they definitely are pursuing voluntary models more aggressively. I think the most prominent example of that in this space is a new bundled payment model called Bundled Payments for Care Improvement Advanced, or BPCI Advanced, and that's basically an evolution from the original BPCI program, which is wrapping up very soon. And that was a very large voluntary bundled payment model that showed actually pretty similar results to the CGR program we evaluated in joint replacement, but it also spanned a wide range of other conditions.
Right. I know that from the provider community that's been involved in that demonstration seemed generally positive about the results, even though it hasn't fully wrapped up and been reported out.
Yeah, I think it's interesting because it depends a little bit on whose evaluation you look at. I think, the story across, if you look at the most recent report released by the federal contractor called the Lewin Group, which looked at the first 3.5 years of the program or so. When you ask is it generalizable, it basically looks like all of the bundle types in the BPCI program where hospitals saved money. It was basically the same story as in CGR, which we haven't gotten to this yet, but basically that 3% spending reduction we found was almost exclusively because hospitals sent fewer patients to nursing facilities and inpatient rehabs, and instead sent them home, with home health for rehabilitation. And that was basically the story in BPCI as well, which is that it seems like, basically every condition where they saved money, it was largely because they cut spending on post-acute care, which is nursing facilities and inpatient rehab.
Right. The skilled nursing community is up in arms about this paper of yours.
Yeah, well, I know. So, I mean, I think it's, I think that industry is going to have a tough time reckoning with, what is the value they provide. I think, one big challenge is that the way that, first of all, the skilled nursing facility industry, they make a very strong and a profit margin on their Medicare patients. It's been very consistent for a number of years. And, they make money based on a fixed amount of therapy that they provide, which up until recently has not really been very strongly rooted in actually deciding what patients need. It's sort of a little bit circuitous that SNFs or skilled nursing facilities get to decide what patients need, but they also get paid more for providing patients with more therapy. So I think there has been, some laziness in the community that, you can just discharge a patient to a skilled nursing facility. They're happy to take them because a lot of these patients are actually pretty easy to rehabilitate and they can make a very healthy margin on them. But there's been, because of the current payment system, there's been very little incentive for people to really explore the extent to which patients really need that level of rehab, what's the right level of rehab, how many patients really need to go. I think everyone's just kind of basically been, sending patients in the way that they feel like is appropriate and not really questioning it too much because everybody's making money, we're all happy. But the truth is that a lot of patients are probably going to these nursing facilities who don't need to be there. But there's been very little research or introspection as to who is that population.
Have you looked at, or are you thinking about the development of remote technologies as supplementing the traditional home health visiting nurse model, and whether those technologies are among the things that can support the positive outcomes in the home health post-surgery care model?
So I think that's a really interesting space. To what extent can we really make the delivery system for patients after discharge much more sophisticated and use technology to actually deliver the right amount of care that patients need, as opposed to just, assuming that everything needs to be a nursing visit or they need to be in a nursing home. It is interesting that actually the CGR program included a telehealth waiver, which basically meant that hospitals participating in CGR could bill Medicare for telemedicine visits without a lot of the administrative requirements that Medicare puts on other providers to get paid for telemedicine. And it looks like adoption of that telehealth waiver was really minimal. Like very few hospitals really engaged in it. That could be more a reflection of what Medicare pays for than the value of remote monitoring. But I think that the big picture is that it's a really fascinating idea, but there just aren't a lot of takers right now. And I think there's small studies and people are exploring it, but it's definitely not a system-wide trend at this point. And I think the payment system has a lot to do with it, but also just the enormous inertia of the healthcare system, kind of moving to some new model. It just takes years and years and years.
Right. I think as some of the payment rules change in that area, we'll see more movement, as you say. If you're just joining us, this is David Harlow at Harlow on Healthcare. We are speaking today with Michael Barnett at the Harvard School of Public Health. Michael, we were talking a little bit about other demonstrations, other CMMI experiments, and I'm wondering if there are other particular areas that you would like to see CMMI focusing on in order to further develop the evidence that we've seen in this particular demonstration, or related areas, or following through. I know in your paper you highlighted the fact that some of the savings here increased over time, perhaps as participants became more accustomed to the context they're working in. If this becomes more regularized, perhaps we see even greater results.
And so when you say what new programs I'm interested in seeing CMMI work in, do you mean around bundled payments or just in general?
It was starting with bundled payments, but I'm interested more broadly as well.
So, I think, I'm very biased as a researcher, but I think that these mandatory payment models where CMS takes a program and then actually randomizes in some way participation in one program versus another are actually really, really valuable. And, if I could have some, if I could, snap my fingers and have CMMI, do something to change their approach, I think it would really be pushing the idea of actually randomizing evaluations much more as a part of their culture than it is right now. And Also, this is less a payment model I want them to test, but exploring ways of like how can we actually speed up the cycle of evaluation and implementation right now, because it basically is taking 4 or 5 years for every single one of these to really kind of come to fruition. And that is a very slow process if we're trying to make healthcare move, in the right direction in the next, basically in the next 5 to 10 years. Like, there's only so many programs we can really get running in that time period. That being said, I think what I would like to see more explicit consideration of is the fact that we have a lot of different payment models floating around and a lot of different payment incentives. So there's accountable care organizations, ACOs. There's bundled payments across a wide variety of conditions. There's all sorts of value-based purchasing programs for hospitals, for SNFs, for home health agencies. There's the readmissions penalty program, which is always a source of controversy. There's a lot of different programs here. And I think, we're probably moving towards a system where some mix of those is really probably, what's optimal to help nudge hospitals in one direction versus another. But I think there's very little explicit exploration of that actually. And it's possible that, really, it's just sort of a certain set of medical or surgical conditions paid as bundles are really what's best in an AC, combined with an ACO, and that it's not either ACO or bundled payments, but actually a combination of the two. And I think to the extent that that can be explicitly considered, I think we'll kind of, actually start moving towards a payment system that where we're not just kind of constantly experimenting, but actually iterating towards something with growing savings.
I would certainly agree with that. It'd be interesting to actually be able to know, well, this sort of payment model is going to work for these sorts of conditions or treatments, and another sort will work elsewhere, as you were saying before, looking at procedures versus chronic care kinds of issues. Sort of more generally, to me, I've always seen a problem inherent in many of these shared savings programs, because the provider participation is based on sharing part of the savings measured against some base year, and that base year over time keeps moving to a lower cost later year. So there's this ratcheting down. In order to be able to participate in some shared savings, you need to bring your costs down year over year over year. And eventually, I figure you got to reach a breaking point. There is going to be some minimum level of care that is necessary. And then at that point, people aren't seeing bonuses. And then what happens? People lose interest. People no longer participate. We've seen in the ACO, earlier iterations of the ACO program, there was very little interest in participating in downside risk. Understandably so, but at the same time, there's this danger, I think, of sort of reaching the end of the line within a couple of years, and then what? Do you think that's a reasonable concern? Do you have a perspective on that?
Yeah, so I mean, I think it's definitely a real concern. I hear it a lot from people that are people in the administration of health systems or executives, which is how do we it's a race to the bottom the way a lot of these programs are designed, and how do we actually keep doing that in a way that's not going to how do we know when we've gone too far and we're going to start harming patient quality? It is I think one thing that our evaluation raises the question of is if everybody is cutting spending by just restricting the use of post-acute care. So really SNFs are the piggy bank for all these payment programs. Where does that stop, right? Like how do we know that we've gotten to basically, more or less as much SNF care as patients need? And then where do you go? And I think I can't claim to have a 100% confident answer to this problem, but I do think that, these payment models need to have some built-in flexibility and responsiveness to what's happening in the overall market. And to the extent that hospitals are able to reduce spending overall to a certain amount, but we're getting diminishing returns, there needs to be a way to reward them once we think they've gotten to an acceptable level of efficiency, basically reward them for either maintaining that level of spending or having growth that does not exceed a certain amount. So it's really all about these benchmarks, right? And that I think what we don't know is when do we stop pushing hospitals further down and just say, look, if you can basically maintain your current level, we're going to reward you. I think that's an unexplored question right now. We don't really know exactly because we're also focused on just getting people to cut spending in some way, in a way that is greater than 1% or 2% or 3%.
Okay, so I guess the next level question is, what costs are we going to ask you to try to cut, or the way you describe it just now, it makes it sound like it's easier for the hospital to eliminate costs that are outside its four walls, harder for the hospital to eliminate costs that are inside its four walls. Maybe more difficult to do that, whether structurally or otherwise, to initiate that kind of cost cutting or closer self-examination. And I suppose the next level demonstration might need to be an experiment that focuses on that rather than on the 90-day episode.
Yeah, it's been very hard to get hospitals to really cut spending in a meaningful way with the coexisting with standard fee for service. I think one great example of this is how difficult it has been to move policy in the right direction for these Part B payments for infusion medications and the 340B discount program. And so these are both programs where basically a lot of hospitals are making a lot of money by prescribing more expensive drugs to patients, and they actually can get higher payments by using more expensive chemotherapy or more expensive infusion medications. And the actual value and comparative effectiveness of using those more expensive medications is underexplored in a lot of circumstances. And I think a lot of the lobbying against potential changes in this program have really been about trying to argue vociferously that the most modern possible medications that are the most expensive are still providing a lot of value to patients, that we can't restrain physician choice. And I think just sort of the difficulty of changing a program like that, where the incentives are so clearly misaligned, shows, I think, how hard of a fight this is going to be to actually get hospitals to reconsider how they spend their money.
Right. Well, I mean, the programs that you describe are perhaps, at least the 340B program is, at least in theory, set up in order to support at-risk institutions or otherwise under reimbursed institutions. So it's sort of a fix that's being applied, and then maybe the fix, I think you're suggesting, is being exploited in a way other than how it was originally intended. And maybe if we just did something a little more directly, then that would be more useful, if there were a bump up in general rates for these protected classes of hospitals rather than trying to give add-ons here and there.
Yeah, and with 340B, we're kind of getting a little adrift here, so I don't want to hijack it too much with this other program. But the issue is that hospitals can kind of game, in a way, getting into that safety net status. And the question is, are the hospitals that actually can define themselves as safety net, are they using this extra 340B payment to do what CMS wants them to do, which is actually treating more underserved populations and helping to reduce disparities and investing in the community? Because a lot of these hospitals that actually have a high proportion of safety net patients are actually very wealthy academic medical centers. So that's one issue with the 340B program. I think another example, by the way, where it's been so hard to really to make a real dent, as an example, is the Maryland's global budget system, which has been celebrated as a promising model to really keep down hospital costs at the state level. And in a way, the government basically in that scenario, the Maryland government completely controls costs, right? They set exactly how much hospitals get paid. But the idea is that, within that global budget, hospitals are supposed to be doing less stuff, right? And they're supposed to actually be recouping the savings. But I think, in the most recent evaluation that some of my colleagues at Harvard Medical School did, it doesn't really look like actually utilization changed all that much, particularly compared to nearby similar regions. And so, overall, it's just been pretty disappointing with different payment models to see truly transformative change in hospitals. It's been very incremental, or almost nothing in a lot of payment models so far. That's one of the reasons why we're excited about our particular paper, is because it does seem like something's actually happening. But as you pointed out, it's not within the hospital mold.
So any last thoughts about this demonstration in this paper?
I guess I would say this patient selection issue is a big deal. So I think a lot of observers have been pretty concerned that when you do bundled payment models, the incentive for hospitals is to only treat patients that seem like they will be as cheap as possible, right? So wealthier, healthier patients with more social supports. And we're going to leave behind a lot of the patients who are the most expensive and the most vulnerable. So patients with a poor social support system, minorities, patients who are frail, and with more illnesses. So what we saw in this program is we looked actually at the change in the patient mix of joint replacements that hospitals in the bundled versus non-bundled groups were doing. And we really didn't see much change, particularly when you consider patients kind of as an overall package. The one little blip that we saw is it does seem like there is a pretty small, like a 5 to 10% relative decrease in the proportion of disabled patients that were treated at hospitals in the bundled payment program. We did so many different comparisons and slices of the data that it's not clear that that's just noise or if it's a real trend. So we need to keep an eye on it. But I think the big picture is that there isn't a major story of patient selection appearing to be the dominant strategy for hospitals, that their dominant strategy has not been to just say no to patients that seem expensive. I have heard of some hospitals where actually they are explicitly having those conversations, and orthopedic surgeons are kind of talking about doing exactly the thing we want them to avoid. But the data says on average, it doesn't seem to really be happening on a large scale.
So to wrap up, Michael, I want to ask you, if you were to wake up tomorrow and find yourself 5 years in the future, what is one thing, either in one of these programs we've been talking about or in healthcare more generally, that you would hope or expect to see has changed drastically?
I guess there are many different things, obviously, that can change in the healthcare system. And, as a researcher, I'm kind of, struggling with proposing something that's kind of, where I'd love to see the change, but I have no idea what the policy pathway is versus something which is maybe a bit more modest, but I think could kind of lead to larger changes in the future. I'd say that I guess I'll list two things, maybe, even though you said just one thing. I'll answer the question I wish you had asked. So one is that I really do feel strongly about these randomized evaluations. But I think if CMS, if 5 years from now, I could see that basically Secretary Azar and Seema Verma basically really committed to the idea of let's try to change the rules a little bit so we can do more rapid randomized evaluations of things that we hope are going to work. And then we could actually really get through ideas more quickly and try to make changes that are actually going to make a difference. So I think, more openness to that would, I think, really, we'd really be able to start changing the healthcare system in a really fundamental way rather than just sort of hemming and hawing about these voluntary programs for a decade and then deciding to move on somewhere else. The second thing, I think this relates to a prior conversation, is what I'd like to see in 5 years is I think we need to start to hold hospitals accountable for their role in the enormous growth in costs, across all healthcare spending, but also within Medicare. And, we know that there's many different aspects to this. Some of it is broken payment systems like this Part B, medication payment system where they get a percentage of the total cost of the drug. Another is consolidation and the fact that hospitals are negotiating higher and higher prices from non-Medicare insurers. And I think it can be very hard politically because hospitals are very powerful and they have very strong reputation. But I think it's something where we're probably never going to make a dent unless politically, both Congress and CMS can actually recognize that hospitals are a significant part of the problem, that we need to work with them to come up with how can we make policy changes that will actually help them move in the right direction, and acknowledge that things will have to change because of that. Less money will be flowing into them. Like, that's the problem. You can't save money in healthcare without anybody feeling some pain. Somebody needs to have slower growth than they would have otherwise expected.
Well, thank you, Michael. I think you've summed it up nicely. We have a research problem and policy and political hot potato on our hands, as usual. Thank you for joining me.
All right. It's my pleasure. Thanks for having me here.
You have been listening to Harlow on Healthcare. Join us at HealthcareNOWradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.